All right, welcome to Chapter 17 lecture on the pelvis girdle. So following along on your lecture notes, we're going to talk about the sacrum. So the sacrum, posterior aspect of the pelvis. It is actually 5 bones that have been fused into a single structure that we call the body of the sacrum. You'll also hear people reference it that it's the keystone. So if you ever see a brick archway, the one or two in the very center that are a little bit different shaped, that's the keystone. Without the keystone, the entire arch would crumble and fall. So think about it. The spine sits on top of the sacrum. The sacrum distributes the weight to the pelvis, down to the hip joint, all the way to the feet. So it's the keystone. Next, we have the coccyx, or the tailbone, and then what's called the innominate bones. And what it is it's a fusion of all 3 pelvic bones: ilium, ischium, and pubis. So this right here in the very center is the acetabulum. It's where the hip joint articulates, and you can see that all 3 bones come together right there. Now, pelvic movement, we have an anterior pelvic tilt, and so that's where the ASIS tips forward. A posterior tilt, ASIS kind of roll in a backwards direction. And then a lateral tilt. All right, so in your textbook, take a look at page 288 and 289. So I may have made an error in the first lab yesterday when I was talking about pelvic tilt. On page 289, look at figure 17-6. So a left pelvic tilt. When one leg leaves the ground, the pelvis on that side becomes unsupported. That causes the pelvis on that side to drop slightly. Therefore, the lateral tilt is named by the unsupported side. So again, if I misspoke in the first lab yesterday, I'm trying to correct it now. Pelvic rotation. Okay, so this occurs when we walk, when we ambulate. And it's a translation of allowing the upper body to rotate kind of in an opposite direction as the lower body. So as you step forward with the left leg, the pelvis will rotate in the same direction. So the left side would rotate forward. As you step forward with the right leg, the right side of the pelvis begins to rotate in an anterior direction. So it is transverse plane. Hip hiking is a compensation strategy that allows people to potentially walk with injuries. And it is the non-weight bearing leg to prepare forward. So if you've ever had a knee injury where it's hard to bend your knee, in order to propel forward, what you kind of do is do a little bit of a hip hike on that side and then swing that leg forward. And a Trendelenburg gait pattern is a loss of a force couple related to pelvic stability. So if somebody has a stroke that affects the left side of their body, so it would be a right-sided CVA, left side of the body's been affected. If they're weight bearing on that left leg only, and they pick the right leg up, the pelvis wants to tip. I can demonstrate this in lab when we get to actual gait mechanisms in a couple of weeks. Moving along to pelvic joints, we have the sacroiliac joint. So the sacrum and ilium. This is another joint that has linear motion, and it's set up in a way that it transfers weight from the spine to the innominate bones, so the pelvic girdle. So a lot of stability, not a lot of mobility. Pubic symphysis, that's where the two pubic bones come together on the anterior portion of the pelvis. If you look on page, give me a moment, I will find it here in your textbook. 285, 17, figure 17-9, you can see the pubic symphysis. It's not identified on that particular diagram, but it would be at the bottom of the page where the two pelvic bones come together. Those bones are separated by fibrocartilage, so a little bit of shock absorption, a little bit of motion, again, linear motion. And then the lumbosacral, so this is the area where the L5 has a disc between it and S1, and there's articulation surface. So B on this particular image that we're looking at, B is considered the superior articular process between L5 S1. When we get to the spine, I'll talk a little bit more about superior inferior articulation points. Next part that we need to talk about is true pelvis versus a false pelvis. So it is just an indication of where we are looking within the pelvic girdle itself. So the false pelvis is made up from the superior aspect of the iliac crest down to a region of the superior pelvic inlet. So take a look on page 282 in your textbook, figure 17-2, and it shows you the general region of the false pelvis. Now the false pelvis does not contain any pelvic organs. The true pelvis is from the pelvic pelvic inlet down to the pelvic inlet. And it does contain certain GI organs, urinary tract, some reproductive organs, and the birth canal in females. And then looking at the pelvis, we can tell the difference between males and females. And there's a couple ways of doing it. Again, page 282 in the textbook. Female pelvis are typically broader across the superior aspect. The other way, and this is the way I like to look at it, is looking at the pelvic arch. So if you look at 17-3A, you can see that the male pelvic arch is shaped like this, whereas the female pelvic arch is shaped more like this. And again, that's part of that birth canal. What we can't see on these images very well is what's called the iliac spine. On a male, the iliac spine really come to a sharper point. On females, they're smaller and more rounded. And again, that's part of that birth canal. And the last part of this lecture will be taking a look at the ligaments. Please read through the book. I only want you to commit to memory what I talk about. So yes, read it. Understand there's a lot more to these ligaments than what I'm going to talk about. But for the purpose of this class, I want to keep it as simplified as possible. So, anterior sacroiliac. The function of that ligament is it reinforces the anterior hip joint. The interosseous sacroiliac is the strongest of the sacroiliac ligaments, and it also reinforces the anterior hip joint. Posterior sacroiliac, we have the short posterior sacroiliac, and it prevents anterior movement of the sacrum. The long posterior sacroiliac prevents inferior motion of the sacrum. Sacrotuberous contains fibrous connections with gluteus maximus and prevents anterior movement of the sacrum also. Sacrospinous works in conjunction with sacrotuberous. So sacrotuberous, sacrospinous form a portion of the sciatic foramen. So that would be ligaments that kind of encapsulate, they form part of the arch that the sciatic nerve will pass through. Iliolumbar limits rotation of L5 on S1. And the lumbosacral provides stability between L5 and the sacrum. All right, gang, follow along in your textbook. There's only one lecture for chapter 17. I will get chapter 18 done here in a few moments.